Usually, when we talk about getting a medical diagnosis, there's this built-in expectation of, like, precision.
Right. Oh, for sure.
Like, if you
Yeah.
break your arm, the doctor just throws an X-ray on the screen, they point to the jagged white line, and you're like, okay, there is the problem. You see it, you understand it, and the path to fixing it is totally clear.
Right. Because that visual evidence provides a kind of psychological comfort. We have this profound bias toward conditions that we can just easily categorize and, treat with a standardized protocol.
Exactly. But stepping into the world of female sexual dysfunction, and specifically orgasmic disorder, is, I mean, it's like trying to read an X-ray where the machine is fundamentally broken.
Yeah, that's a really good way to put it.
The diagnostic landscape is just super murky.
Hmm.
The mechanisms are all tangled up in neurobiology and psychology, and the treatments are, well, they're often heavily marketed to you long before they're rigorously proven.
Which is exactly why we're here.
Right? So today on the Deep Dive, we are tackling a highly requested question from you guys. We want to know, can injecting your own spun-down blood into your most sensitive anatomy actually cure delayed orgasm?
It's quite the question. And I mean, orgasmic disorder, which is basically delayed, infrequent, or just absent orgasms despite adequate stimulation, it's a condition that really lives in the shadows of modern medicine.
Totally in the shadow.
Yeah. We're looking at data showing over 40% of sexually active adult women experience some form of female sexual dysfunction, or FSD. I mean, think about that.
40% is massive.
It really is. If a respiratory issue or a heart issue affected nearly half the population, the research funding would just be astronomical.
Oh, yeah. Public awareness would be everywhere.
Right, but instead there's this historical silencing around it. Patients feel embarrassed to report their symptoms, and then when they do, providers often just they lack standardized treatments to even offer.
And that massive communication gap, it just creates the perfect environment for experimental treatments to sweep in. Which brings us to the O-shot.
The O-shot, yes.
Yeah, it's this trademarked procedure promising these dramatic regenerative results. And we've got a really fascinating stack of sources to unpack this today. We've got a 2022 clinical study from Poland showing, like, absolute miracle-level results.
But then we're weighing that against a massive 2024 university review of clinical trials that basically calls those results a statistical mirage.
Exactly. And to figure out how you should navigate this gap between, innovation and clinical proof, we're also going to look at some public health consent protocols from Wales.
The tension between those small local success stories and broad scientific skepticism is, honestly, it's where the most important medical truths usually hide.
Yeah, I totally agree. So, okay, let's unpack this. Before we look at whether it actually works for delayed orgasm, we need to know what the O-shot fundamentally is.
Right. The biology of it.
Yeah. We're talking about autologous platelet-rich plasma, or APRP, which the medical community has used for years, right?
Oh, absolutely. They use it in orthopedics to heal tendons, in dermatology for tissue repair. It basically relies on the body's own regenerative mechanic.
Right. And the actual administration detailed in this 2022 Polish study from Gynekologia Polosnik 2, I hope I'm saying that right. It reads like a masterclass in localized cellular therapy.
It's very precise.
Super precise. So the clinician draws 10 milliliters of your blood into a sterile tube with an anticoagulant. And the magic, so to speak, relies entirely on the centrifuge.
Yes, the dual spin process.
Right. They use a really specific two-spin method. First, they spin the blood at 2,500 revolutions per minute for 3 minutes, and then they aggressively ramp it up to 4,000 RPM for 15 minutes.
And that density separation is completely non-negotiable if you want to isolate the potent stuff.
Because it separates the layers.
Exactly. The heavy red blood cells sink to the bottom, and that leaves this highly concentrated middle layer of platelets right beneath the platelet-poor plasma. Extracting that specific middle layer gives you a serum that's just packed with the patient's own cellular signaling mechanisms.
Wow. And then the injection protocol is just as intense. So after applying a topical anesthetic, the doctor uses a tiny 31-gauge needle to inject this plasma into the anterior vaginal wall.
Which is the region we traditionally associate with the G-spot.
Right. And then directly into the tissue around the clitoris at 4 cardinal points, so 12, 3, 6, and 9 o'clock. They're basically creating a targeted ring of plasma droplets right around the primary locus of female sexual pleasure.
What's fascinating here is the biological theory driving this, because reaching a climax has structural requirements.
Like blood flow.
Right. The clitoris is this incredibly complex, deeply internal organ, and the surface glands is packed with thousands of nerve endings. For an orgasm to actually happen, that localized network needs rapid vasocongestion, so massive blood flow and hyperresponsive neural sensitivity.
And the platelets help with that.
Yeah, platelet-rich plasma contains extreme concentrations of VEGF, which is vascular endothelial growth factor, and EGF, epidermal growth factor.
So basically like injecting biological fertilizer straight into the roots of the genital nervous system.
That is a great analogy. The intention isn't just a temporary rush of blood, like you'd get with Viagra. The goal is actually neoangiogenesis.
Which means creating new blood vessels.
Exactly. Creating new capillary networks and triggering stem cells to repair dormant or damaged nerve endings.
So by physically rebuilding the hardware down there, the anatomy theoretically becomes more capable of engorging with blood and sending sensory data to the brain.
Right. To trigger an orgasm faster and with much greater intensity, it's a structural intervention for a functional problem.
Okay, so the biological fertilizer theory sounds flawless on paper, but the real test is what happens when this hits actual patients who are struggling with profound sexual dysfunction.
And this is where that 2022 Polish study comes in, right? Because the outcomes they reported were kind of staggering.
Honestly, yeah. So the researchers tracked 30 women, mean age of about 51. So a lot of them were navigating menopause or the structural aftermath of childbirth,
And to measure the results, they used the FSFI, the Female Sexual Function Index.
which is a highly validated questionnaire, right?
Right.
It measures desire, arousal, lubrication, orgasm, satisfaction, and pain.
Yes, and a total score below 26.55 means you clinically have sexual dysfunction. Prior to the O shot, the baseline average for these women was 16.50.
Wow, so severe multi-domain dysfunction.
Exactly.
But then, 4 months post-procedure, that overall average leaped to 28.50. They completely crossed the threshold out of the dysfunction category.
Which is incredible.
But looking strictly at the orgasm domain, since that's our focus today, the average score jumped from 1.50 to 4.0.
That is a massive shift. In the context of that survey, going from 1.5 to 4.0 basically represents a shift from rarely or never having an orgasm to achieving climax most of the time.
It's a fundamental restoration of function. And it totally impacted their mental health, too.
Right, the psychological piece. The study used the FSDSR, which measures the emotional burden of FSD. You know, the guilt, the inadequacy, the sheer frustration. A score of 11 or higher indicates severe distress. Pre-treatment, almost the whole cohort was highly distressed. After the plasma therapy, 83% of those women dropped into the non-distressed category.
See, that sounds like an absolute miracle cure. But I have to point out a glaring discrepancy in these data tables that kind of challenges that narrative.
Oh, the pain scores.
Yes, the pain scores. The overall scores doubled, the distress vanished, but the specific domain measuring pain during intercourse only dropped from 2.80 to 2.50.
Which is not statistically significant.
Not at all. So if this plasma is regenerating tissue and building healthy new blood vessels, why isn't it fixing the pain?
Well, that actually makes perfect sense when you look at the mechanism. The O shot targets superficial mucosal tissue and clitoral nerve endings. Enhancing that surface blood flow is what you need for arousal and orgasm. But pain during sex dyspareunia that frequently comes from deeper structural issues, things like endometriosis, severe pelvic floor spasms, deep scar tissue, you can't fix that with surface-level nerve regeneration. The APRP is a hyper-targeted tool for sensitivity. It's not a systemic cure-all for deep pelvic pain.
Okay, that definitely clarifies the boundaries of what this actually does.
Oh.
But still, an 83% drop in distress and a massive leap in orgasms, that should redefine gynecological care everywhere.
You would think so.
So why isn't it? Why does the O-shot remain this out-of-pocket niche procedure instead of the gold standard?
Because we have to pull the lens back. We have a single 30-person retrospective study at a private hospital. But medical consensus demands reproducible, large-scale, placebo-controlled evidence.
And that brings us to the Oklahoma State University review from 2024.
Right. Hunt and his colleagues looked at the U.S. National Library of Medicine's clinical trial database to see if these miraculous results actually held up.
The methodology here is so fascinating because they didn't just read published papers, they audited the actual pipeline of clinical trials.
Yeah, they filtered down 110 database results to 18 highly relevant trials testing PRP for female sexual dysfunction.
And the immediate red flag was the completion rate. Out of those 18 trials, only 33.3% actually finished.
A nearly 67% abandonment rate is a massive warning sign. Trials like this usually get halted because they run out of money, they can't recruit enough people, or the early data is just so bad that ethics boards shut it down.
Wow. And the findings from the few that did finish? Absolute bombshell. Out of those rigorously managed large-scale studies, 0 found statistically significant improvements in sexual satisfaction or arousal across the board.
0. The narrative of guaranteed orgasms just evaporated under real scrutiny. The researchers bluntly concluded that the aggressive marketing for APRP is fundamentally disconnected from the actual large-scale clinical evidence.
It's like we're looking at two entirely different realities.
Completely.
But if you think about it, reconciling them comes down to how the research was done. The 2022 Polish study is basically the perfect Instagram snapshot of the O-shot. It's heavily curated, it was retrospective, which introduces selection bias, it had a tiny sample size, and crucially, no placebo group.
Right. Every single woman in that clinic knew they were getting a highly touted regenerative treatment.
Exactly. Whereas the OSU review is like looking at the entire unedited camera roll. You see all the abandoned trials, the blurry data, the lack of statistical significance.
And the Women's Health Clinic guidelines provide a really good bridge between those two extremes. Their internal guidance on APRP is incredibly cautious. They note that while the marketing is all about arousal and orgasm, robust clinical trials are just lacking.
Yeah, they point to major regulatory bodies like RSQG and NICE in the UK.
Right, and both of those firmly classify the O-shot as an experimental procedure that needs way more research before it becomes routine.
And that word experimental carries so much weight when you're the actual patient sitting in that paper gown.
It really does.
You're carrying this heavy psychological burden of FSD. You're paying thousands of dollars out of pocket, and the overarching medical consensus is telling you, hey, this is unproven. Navigating that requires a masterclass in medical ethics.
Which is where the 2023 Consent to Examination and Treatment Policy from Public Health Wales comes in. It perfectly frames the ethical stakes here.
Even though it's a general policy for their public health system. Right?
Exactly. The philosophy applies beautifully to experimental private treatments. They define informed consent not just as signing a waiver, but as a transparent educational exchange.
I have a line from the policy right here. It says, you should be aware of all of the significant risks, benefits, and alternative treatments, including no treatment, so that you can make an informed decision.
That inclusion of no treatment as a valid alternative is so crucial.
Because it reminds you that you don't have to do this.
Right. And applying this to the O-shot means providers have to be uncomfortably honest. They have to echo the caution of the Women's Health Clinic. Patients need to know the long-term efficacy is totally unknown.
Like, we don't know the half-life of these effects.
Exactly. The biological fertilizer might spark new blood vessels today, but do those vessels stick around for 6 months? A year? We just don't know.
So a clinic promising a flawless cure without mentioning that 67% of clinical trials were abandoned, I mean, that is a massive failure of informed consent.
Absolutely. True medical advocacy means treating the patient as an intelligent partner. You outline the promising cellular logic, but you also acknowledge the giant gaps in the literature.
And addressing orgasmic disorder really has to start way before anyone even turns on a centrifuge.
Yeah, it starts with finding a provider who actually listens. Someone who normalizes your sexual distress without judgment and frames the O-shot as just one potential tool in a broader toolbox, not some standalone magic wand.
So, synthesizing everything on the desk today leaves us with a really nuanced reality. Can the O-shot actually help with delayed orgasm? I mean, biologically, it makes sense. Using concentrated platelets to build clitoral nerve endings is a compelling mechanism.
And we do have small, localized studies showing extraordinary leaps in orgasm scores and huge reductions in distress.
Right. But the overarching clinical data demands serious skepticism. When we look at large-scale trials, the statistical significance just vanishes. And major medical institutions are resolute in calling it experimental.
So if you are navigating orgasmic disorder, your distress is entirely valid, and while the APRP shot is an intriguing option, you have to approach it demanding absolute transparency from your clinic.
Well said. But there is one final, totally fascinating psychological component to all of this that our sources touched on.
Oh, the placebo effect.
Yes. Because female sexual response is this intricate web of vascular, neurological, and emotional triggers. The brain is the primary sexual organ.
Always.
So the placebo effect in FSD trials is notoriously powerful. If you think about the whole ritual of the O-shot, from the perspective of a patient whose distress has been dismissed by doctors for years.
The ritual itself is a form of intense clinical validation.
Exactly. You walk into a clinic, you pay a premium out of pocket, you literally watch your own blood drawn and spun in a centrifuge, and then a medical professional spends an hour hyper-focused entirely on your anatomy, your pleasure, and your absolute right to achieve an orgasm.
They're treating your sexual satisfaction as a serious, solvable priority.
Yes. So if your orgasms suddenly become more frequent and intense after that,
Yeah,
it leaves you with a really profound question to mull over.
it really does.
How much of the cure is driven by the physical growth factors regenerating your nerves, and how much is just the staggering psychological relief of finally being heard? Something to think about. Until next time, keep asking the hard questions, and we will keep diving deep